Welcome everyone to today's webinar, How Two Systems Are Using Virtual Triage to Transform Patient Access. On behalf of Becker's Healthcare, thank you for joining us today. Before we begin, I'm going to walk through a few quick housekeeping instructions. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access that recording. If any time you don't see slides moving or have trouble with the audio, please try refreshing your browser, and you can also submit any technical questions into the Q&A box, and we're happy to help. Today's webinar will be hosted by Matthew Hannes. Matthew is the head of strategy for NetChat and also the host of the Business of Healthcare interview series. Previously, he held leadership positions with Mercy, Thomson Reuters, and AT&T. He is trained as an economics and has worked in health tech for 25 years. Matthew, we are excited to get started today.
Thank you, Kelly. Well, welcome everybody for joining us. This webinar has attracted a huge audience. We've got a lot of senior leaders from many different providers, and I think I know why. Today we're gonna tell the story of delivering state-of-the-art patient access. And this story is really a journey that started many years ago. I'm gonna provide more context in a moment, but the story started in 1999 with a little girl named Isabel. And fast forward to today, it's unfolding right before our eyes in leading health systems like Banner Health and Ardent Health Services. Leaders, oops, sorry, getting used to this. There we go. So leaders involved in these organizations are on the panel today. So we have Heather Francis from Banner Health, Reed Smith from Ardent Health Services. I'm Matt Hannes from NetChat, and Don Bauman from Isabel. We'll do a little bit more of an introduction for each of those folks and get them into the conversation in a couple of minutes. But first, I'm going to play my host role and give you a little bit of background. So you may be wondering why we chose the Cloud Gate, better known to those from Chicago as the Beam, as part of our artwork. And beside it being, kind of a really cool image, it reminded us of the business problem that we're tackling. So every day, millions of people call our organizations to schedule appointments, arrange procedures, get results, and a myriad other things that, a myriad of other transactions that they need to complete. And getting patient access transactions right is the foundation of optimizing access, optimizing quality, safety, outcomes, including our own outcomes of profitability. We as providers have to be profitable. And so we can probably all agree that those millions of phone calls are oftentimes mediocre experiences at best. As good as we all seek to do a great job with that, we know that consumer experience is sort of like the Chicago Beam. It's got all those weird angles and nooks and crannies and distortions to it. It's a very, very complicated workflow, a complicated experience. And getting patient access right at scale is extraordinarily hard to achieve. That's a complex transactional problem. And if you think about it, think about what we're asking our non-clinical agents, those agents who are answering the phones to schedule appointments for your providers or trying to get an imaging appointment scheduled or a lab test. Think about those people who schedule and facilitate referrals who often only have a high school education or maybe somewhat above, some of them certainly higher than that, but we're talking about people that we're asking to solve a really complex multivariate equation in less than 10 minutes. Find the right provider at the right location, accepting the right insurance, and available at the right time for this patient for whatever their need is. And then, by the way, we also ask them to do that scheduling in an old billing system, which we affectionately call our EHR. So it's, the permutations here that we handle in transactions that involve patient access are enormous. The variation is wide. The risk for error is high. This is a really, really tough problem to solve. And it's also very labor intensive. And this is labor who could be more valuably serving patients in other ways. So let's call virtual triage, for the purpose of our discussion today, let's call virtual triage the set of technology and organizational change needed to solve this problem, this patient access issue. It's the automation, it's automating the complexity out of the patient access experience. So let me first sort of pose the business case, and then let's get to introducing our panelists. So the business case here is, there we go. So the business case, whether you want to call it virtual triage or virtual patient access, some of the other terms here, symptom checker and so forth, virtual triage is trying to automate a bunch of processes, and you need a bunch of ingredients. You need a symptom checker, you need a digital front door for the consumer to engage with, and so forth. You need a self-service interface for patients and caregivers to complete patient access transactions. You need a way to do that digitally. You need a way to do that securely, which means you're probably using a portal or chat, or it's done by voice, which is what a majority of our scheduling transactions are done by. And of course, surprise billing regs require that we can quote out-of-pocket costs as we schedule. So virtual triage also has a financial implication to it. The use cases are pretty obvious. It's all the permutations of people trying to get access to care for themselves or somebody they're providing care to. And there's all sorts of complicated different nooks and crannies there, whether you're trying to get an imaging appointment or you're trying to schedule with your physician, or if you're not sure what care you need and need help based on your symptoms. So the business case here is the adopting health systems and medical groups who get this right, who deploy this technology effectively, whatever vendor or brand or solution they come up with. But those who improve patient access using virtual triage strategies will improve the quality of their patient access, improve the labor productivity, improve quality and safety faster than their non-adopting peers. So this is an ambitious business case, but we happen to have some people here who are right in the thick of the most thorny problems that you have to solve in order to crack that overall business case. I'm incredibly humbled to host this session with three patient access thought leaders. So Heather Francis is a registered nurse and a master of health administration. She's clinical director of digital integration for Banner Health. She has 15 years of experience at the bedside and then expanded into various leadership roles until the point now where she plays a key clinical leadership role in those experience channels, in finding and helping patients more efficiently get to the care that they need within Banner Health. Next, we've got Reed Smith. He's also a master of business administration. Reed is a longtime health tech innovator, runs a great podcast series, which he'll talk about a little bit, and is the vice president for digital and innovation at Ardent Health Services. And then Don Bauman is the chief executive officer for Isabel Healthcare, which provides some of the key algorithms. So these are our cast of characters to tell this story. There is one more character in this, or one more participant, and that is Triage Bot. So this is a tool that all four organizations work with. And Triage Bot is basically a tool designed to be used to accomplish those virtual care functions. And so it's designed to find the right care at the right cost in less than 90 seconds. So more about that, but very quickly, I want to cover our financial disclosures. So for Reed Smith and Heather Francis, they don't have any financial affiliations here. For me, I'm a NetChat employee. So if any of you buy Triage Bot, I have an economic incentive for that. And then Don Bauman is an Isabel health employee and therefore has economic incentives around Isabel. Why don't we start off by handing off to Don Bauman, and let's talk about the Isabel story.
Great, thanks, Matt. I appreciate everybody joining the webinar today as well, and the opportunity to talk a little bit about the heart of our fifth cast member, the Triage Bot, or the engine underneath it. It's been developed by Isabel. And I think it's really important for folks to understand why we do what we do at Isabel. Isabel Healthcare is an interesting name. It's really named after Isabel Maud, who you see in the picture here, who suffered a diagnostic error when she was 3 years old. Isabel had chickenpox and deteriorated to the point where she got admitted to the ED and coded 3 times. They paddled her 22 times and finally figured out they missed a secondary infection of necrotizing fasciitis. The great news is she survived the event, and you can see here her climbing Mount Kilimanjaro a couple years ago. But it cast a long shadow over her life with reconstructive surgeries, et cetera. And then the other bit of lemonade that came out of the lemons was that Jason Maud established the Isabel Medical Charity back in 1999. And we started building the engine that you'll see as part of Triage Bot back in 1999 on a curated machine learning platform. And we've been doing that and building that out, tuning that over the last 22 years. And so we look at ourselves as a social enterprise. We're in this to help both providers get to the right diagnosis as quick as possible with our differential tool. And we are also here for patients and agents to help patients the patients get to the right care venue as quick as possible, and help agents help those patients get to the right care venue as quick as possible. So we're really focused very highly on efficiently doing that in the most accurate way that we can. All right, Matt? So given that we've been around for 22 years, there is a long pedigree of validation and big history of depth of breadth of products. So there's 20 peer-reviewed journal articles and abstracts about the efficacy and accuracy of the tool. It's validated for all age ranges. Our differential tool is basically the same engine as the differential or the Triage Bot engine is used and trusted by physicians around the globe to help them build and broaden their differential. That same engine drives the Triage Bot tool to help patients, again, get to the right venue of care as efficiently and as accurately as possible. And we focused on those two components because if you think about yourself or myself or when I had my children or even my grandkids now, I want to get help for my sick child or my sick parent or myself when I'm sick as quick as possible. I don't want to have to go through loads and loads of questions to try to get there. I want to get to the right venue and go as quick as I can and get care. So and I think you'll hear more about that as we go along, but that's the idea and the concept is to help these folks get to the right care as quick as possible. Matt?
So along this journey, starting back in 1999, the next sort of phase of this journey was the NetChat story. We were founded in 2015. We were one of the first to market in the HIPAA compliant chat space. Launched a lot of platform. Launched Triage Bot in partnership with Isabel after a great deal of work. And now hundreds of customers. We've got adoption across pretty much every sector of healthcare. But now I want to pass it over to Heather. And Heather Francis, could I invite you to pop on in and tell us a little bit more about Banner Health, your role and the work that you've done?
Sure. So Banner Health is recognized as a top health system in the country. We operate 30 hospitals, 3 of which are academic medical centers, in addition to other health services in 6 states. We had over 5.3 million clinic visits last year, and that's really the piece where we are connected for our evidence-based scheduling project, which I'm going to talk about today. I feel very fortunate to work for Banner Health that puts such an emphasis on innovation. It makes it fun to come to work each day. And our vision at Banner is that we will be nationally recognized for clinical excellence and innovation, for having highly coordinated patient experience and distinguished people, which is a great vision to aspire to. As a matter of fact, our Chief Strategy and Growth Officer, just recognized our healthcare being one of healthcare's top innovators this year. So just an exciting organization to work for. And if you'll go to the next slide. Customer experience channels, or known as the CEC. And we do a number of functions, but one of those functions is scheduling. All the scheduling that we do accounts for about 5.8 million calls that come in for 129 locations. Specifically for evidence-based scheduling, we're going to be using this tool for our clinic scheduling rather than imaging and some of the other things that we schedule for.
Heather?
And for that part of the business, why we need a tool like this is, if you look at the statistics, 4.5 million calls, 84 locations, 39 specialties. We have a lot of complexity. We're in different states. Like I mentioned, we have different medical groups. And at times in our current state, we have protocols and directions.
Heather, can you hear me? Heather? Yeah, we're getting your audio is breaking up a bit. Could I get you to refresh your screen?
Sure.
Sorry about interrupting your flow. So, whoops. That may have been, that was a catastrophic suggestion. I'll do the best I can to summarize here as she reconnects. So essentially there she goes. Heather, are you able to hear us?
I can hear you. Can you hear me?
You sound much better. So go ahead. You were talking about the, kind of giving a sense of scale. So overall, this channel is scheduling 5.8 million or handling 5.8 million calls. Go ahead, take us deeper.
Right. So I think it speaks to the need that we have for the complexity of the organization that we have with 39 specialties, over 1,100 providers. Since the pandemic, the majority of our scheduling agents who are non-clinical actually work remotely. So we need robust evidence-based tools that can standardize our processes and get our patients in the amount of time that they need to be seen. So that's setting the groundwork. We did start it for internal medicine, pediatrics, family medicine, and OB-GYN with 8 agents in December. We're going to talk a little bit about that process and those results. So if you want to go to the next.
And just to summarize, just to crystallize that, so the overall, you got a ton of calls. A subset of those calls are your clinic. We've got, for the pilot, that'll be about half. You've started with 8 as the pilot patients. Am I saying that right? Or the pilot agents?
Correct. And that was our phase 1 pilot. And I wanted to show you how the view from the agent perspective. So we use a CRM tool called One Banner, and it's powered by Salesforce. And using a CRM tool allows us to manage relationships and interactions with potential customers. It brings data in from our EHR from different systems for a single view for the agent. And you can see here where we've integrated the NetChat chatbot or evidence-based scheduling into the scheduling workflow. So it's right at their fingertips as they're scheduling a patient. Again, it helps the agent understand how quickly the patient needs to be seen. And it also walks the agent through complex workflows like suicidality, or when we need to transfer the patient to 911. It takes them step by step through that process, gathers the necessary documentation where we are, so we can do it by policy, and we have all of our bases covered. It even gives the agent a prompt at the end for those calls that if they need to debrief, to reach out to their leaders. So we've taken every step in that process and accounted for it.
And Heather, could you just like imagine for a moment, you're a patient's calling. Can you just sort of describe what happens? What is the agent experience?
So from the agent perspective, they're indicating why the patient why the patient is calling. So are they calling because they would like to see their doctor because they have a new illness? Do they have an injury that they want to be seen for? Do they just want to reschedule? If the patient is calling and they just want to reschedule and they don't have any new symptoms, then the agent can just schedule without going through the whole workflow, the Isabel questions. And we've built in other things like poison control and mental and behavioral health. So it gives them the right options for all of the different reasons that we have patients calling. They work through that, ask those simple 7 questions. It pulls certain information in directly from One Banner, like the patient's age and their gender, so that it can figure out certain things from that perspective. And then at the end, based on their symptoms that they're reporting and the way they answer those, duration, frequency, pain, things of that nature, it will present to the agent what options they have for scheduling. It might be this patient needs to be seen in the office within 12 hours. But in other instances, it may give options like, they can be seen within the office in 12 hours. We can offer a telehealth visit. Urgent care could be appropriate, or even talking to a nurse with nurse triage. So in the past, the tools that we had, like one symptom resulted in, you need to do this thing. In the way we've developed this is, let's give the agents options so that we can have that first call resolution and we're not doing a lot of back and forth and there's not that ambiguity.
Yeah, it's just such an interesting moment. And just I want to hark back to the earlier part of the conversation. So if you think about this, at the end of the day, that patient that's trying to get access to care is either calling you or looking for a digital front door to do these very same things. And so for Banner, what I found fascinating about this project is you started off with the agent-facing use case in this work. And when you think back to why you undertook this, what was the driver? What was kind of the original starting point for why you needed this?
Well, we always have obviously a high focus on safety and quality, and we want to provide that for our patients, of course. But we just found a need. Again, we have some homegrown tools. We have some different tools that we use by practice, and that's not scalable. If our phones go down in one location and they have the tools to schedule for Tucson, Arizona, let's say, we couldn't transition those calls to another area because we're not all using the same tools. We want it to be evidence-based. We want it to be scalable. We want to be able to cross-skill our agents. And we really needed a tool like this in order to meet those objectives.
And you, just to put a cherry on top, there's a question that came out of the audience. What are the qualifications for these agents? Are they RNs? Are they medical assistants? Or are they a non-clinical individual?
Most of them have no clinical background at all. We do have some agents that transition from an MA role in a clinic and now work with our CEC. So some do have some background, but I would say most are non-clinical, non-healthcare agents. And I would say with your MA population, you always run the risk of somebody, well, in our practice, we always did it this way. This is, they may believe they know more than they do, and you want to have a structured tool like this so that we're doing things that have been vetted with our physicians and is evidence-based.
And that last point, I'm gonna tee up your next slide for you. That last point is a pretty big crux of the matter, and this was your job, right? You in this cross-functional team that did this deployment. And really, in my opinion, and having worked with a lot of health systems across the country, you guys were extremely orderly and methodical about this. But one of the tasks was that if you're going to automate this, if you're going to introduce algorithms here, you have a big group of stakeholders. Talk about that group of stakeholders and what your job is.
Sure. Do you want to? Yeah. So when we started our journey to find a tool or a vendor that could help support what we wanted to do with scheduling, we knew that in order to have that be successful and for there to be buy-in, it couldn't be an undertaking that we did as a CEC on our own. We needed to include the medical groups that we schedule for. Like I said, we have 2 different medical groups, a university division and Banner Medical Group. And we wanted to make sure we had those stakeholders at the table when we decided on the vendor we were going to use. They were very involved in that process. And once we determined we would go with NetChat as our vendor, we really needed to talk to, in Banner Health, we have teams called clinical consensus groups. And what we wanted to gain from them is their awareness and approval of the project, but then also their input on key design requirements. And using the clinical consensus groups is one of the ways that Banner is able to scale and standardize practices is by utilizing that expertise of the CCGs and making sure that we are doing things that are safe and evidence-based, using literature and practice-based evidence. So that's a key piece of how we structure things at Banner Health. The next thing that we did is NetChat comes with a standard recommendations and scoring, but we wanted to again engage with our physician partners to say, here's our starting point, here are the tools that we've used to date. Now let's see where we may need to make some customizations for how we do business or how the medical groups or the physicians practice. And that was, months of work with different physicians from the different specialties to ensure that we had it set up as right as we could. But best laid plans, and even with all of that due diligence, once we started with the pilot, we needed to have frequent check-ins and frequent reviews with our physician champions. And we initiated monthly reviews of data. And we're going to go over in a little bit what has come out of that, but we also developed a clinical governance with these physician champions where if there are quality or safety concerns or concerns from any practice where they are requesting a change to how we use NetChat, then that same physician clinical group will get together and we'll review that case and see if a change is needed or not. So we really set up that oversight governance structure before we ever took one call with the tool.
And I'll switch over to the data slide in just a moment, but one last sort of observation here. One of the interesting things about this is you now have a place for that consensus, right? You now have a place where the expression of what those rules are is laid out very easily, that anybody could look at it. You don't have to be a technologist to see what the rules are. And that's played a role.
Right.
So what's happened? What have you seen so far?
So we have taken over 7,000 calls using evidence-based scheduling with those 8 agents. And like I said, we have a structure where we review the data monthly, and that review has changed because as we meet with the physicians, they might want to see something different in the future. So we're constantly iterating on our reporting structure, taking information about that call from one banner, from NetChat, from our enterprise data warehouse, really connecting the dots, how many people are calling because they have a new illness. So that's our patient intent distribution. What are our different recommendations broken out by age? Because our pediatricians are very interested in things that may be different than what our family medicine doctors or our obstetricians are looking at. So being able to parse that data out and how often do we need to, is the chatbot saying that patient needs to be seen within 12 hours? How often are we getting them in within 12 hours? Because that could be an indicator of, either an access opportunity or were we too risk adverse when we did our scoring and recommendations. So we really slice and dice the data as many ways as we can that provides value and insight. One of the things that we've done recently within the last few months is we've started doing case studies where we're looking at specific scenarios. So maybe it's all of our patients that we've escalated to the ED. We look and follow that case from the time the call was made till the time they have an encounter with one of our emergencies. It's been, like I said, iterative, and as we get more into the process, there's new things that the physicians and we want to learn. But we have made changes too. So we've expanded our recommendation for our pediatric patients. From the data and the case studies that we looked at, we did a few things. We've broken out injury because we were escalating. We felt like, over escalating injuries because it was pulling in some illness, differential diagnoses. So we've created a different path for injury. And then we've also created an overlap with our clinic nurse or our nurse now nurses. If we're going to send a kiddo to the ER, let's get a nurse involved because sometimes that escalation may not be necessary and we can get them in and be seen the same day. So that's the benefit of that constant review and not just creating something, we call it, implement and then kind of leave. We'll be doing this consistently and constantly throughout as we add more specialties.
Yeah, it's wonderful work, and what's I find super interesting about it is the feedback loop that you're creating. You're connecting the dots from what happened in the contact center to where the patient went and what that outcome was. There was a really interesting question asked from the audience. Mia Graff asked, if a patient calls with serious symptoms as chest pain or one-sided weakness, what happens? Does it go to a nurse? Does the agent call 911? Talk a little bit about those clinical exceptions.
Sure. So we do have clinical exceptions set up. We have for pediatrics, for obstetrics, we don't want to delay the call and ask a bunch of questions. So we have created clinical exceptions where if that's the reason they're calling to begin with, we escalate immediately. So in this case, 911, connect them with them.
And there's a variety of sort of escalation paths, whether it's a caller expressing suicidality or a caller expressing violence, or you sort of covered not just this clinical crisis, but a number of other potential crises that happen every day if you're in a call center. Right.
Not just symptom-based, but, like you're saying, situational-based escalations as well.
Well, we're going to come back to you. Don't go anywhere. I got a million questions for you. So let's go over to Reed Smith. And Reed, can you tell us a little bit about Ardent and your role and responsibility there?
Yeah, thanks, Matt. Reed Smith, I'm the Vice President of Digital and Innovation here at Ardent. And you heard Heather mention innovation earlier and a culture of that. We're early in that journey, but fortunate to have an organization that's investing in that space and having a board and an executive leadership team that finds all of this top of mind and the idea of consumerism and the digital front door. And that's a little bit what I'll talk about. So we're an organization that operates hospitals across a number of states and locations, lots of clinics, lots of employees, and not just in one geographical region. So we've got, things everywhere from Tulsa, Oklahoma to Albuquerque, New Mexico, up to New Jersey, and a little bit all over. So you can see a little bit of our stats there across the top. I'd love to reduce the number of websites, but that's a topic for another webinar, another day. But as we think about really where we find ourselves, you see some of the gaps and challenges listed there at the bottom. But philosophically, it's about expectations. Right. So, the consumer, what the consumer expects from our organization when they arrive, at this case, at one of our digital front doors, i.e. a website. I think the last couple of years has done a couple of things, but has really escalated the idea, certainly of virtual and telehealth and the adoption there, but has given us a place where we really have to start thinking about, well, what does the consumer expect based on how they participate online, just in the rest of their lives in banking and with their kids' schools and things like that. And it's, very seldom you find yourself at a website anymore that there's not an option for self-service, right? And that's kind of what we're looking at, is how do you equip people with ways to find what they need, get answers that they need, find the care that they need in a lot of the cases, without having to, either have to talk to somebody in person or go really deep into a website, et cetera. So we're an Epic shop, certainly driving people to my chart you see listed there, and really looking at, what's available in kind of the virtual and telehealth, and how do we get people to care in some of these new and different care delivery methods. All right, so this gives a couple little screenshots. You see this is the Loveless Health System, which is our system out in Albuquerque, New Mexico, but it's very common amongst, if you visit any of our market-based sites. But the idea is, people land on our homepage, how do we make sure that they find the right care? How do we give them an option? Certainly they're welcome to call. We have call centers, we have agents and have directories and all of those kinds of things. But if they want to, and I fall victim to this, I'd rather, I recently, I think, bought, our family a new car because we have too many kids and needed a third row, almost exclusively via text message, right? With the sales rep. Like, I don't want to go there. I don't want to talk to somebody. And so how do we give people different pathways, right? So you see a couple of screenshots here where we were able to work with our clinicians and people that really understand, well, what questions should we be asking, right? So this isn't just about navigating the website, but it's about, in this case, finding care. So you can see in that first screenshot, you see the indication that, an agent, if you will, is online. And so if they are interested or have questions around the COVID testing or vaccines, finding care based on symptoms, even things like billing, certainly finding locations, directions, things like that. they're able to click on those and quickly get them into a pathway of getting that question answered. So you can see there on the right, what are you seeking, and gives people, certainly you can type things in, but quick radio buttons and things like that where you can navigate quickly and find ultimately what you're looking for and get them into a pathway.
And I want to connect a dot here. Actually, I want to connect two dots. So one dot is just to connect back to the beginning and the idea that this mechanism for helping patients find the right care, which is, part of a broader communication strategy, digital front door automation strategy. But this is the self-service approach as compared to Banner, which is coming at it from a different direction. It's coming at it because they have a centralized contact center and they needed to build ways to make that center more effective. Sure. You had a different business problem. You have a lot of markets. Talk a little bit about that variation.
We do. And, we're not, we're an organization that's in a lot of medium-sized markets and even some smaller markets, again, kind of, across the country and, Idaho and, East Texas and up in the panhandle of Texas even. We are equipped with call centers and contact centers. There's not one centralized one, however, but there is an opportunity to certainly supplement that. But the idea was to, equip, at least starting out, have a way from a self-service model, to give people kind of those tools and those mechanisms to, find the information that you're looking for and ultimately be able to come to one of our locations. And so these are all certainly, they have localized branding. So we don't have one kind of corporate brand. And so we're able to deploy this and manage this, but specific for each of those markets based on kind of where they are and what those consumers are looking for, what services are available in those areas and that kind of thing.
And I want to, the other dot I want to connect here is you're talking about it very casually, but the level of complexity that you deal with, and I want to emphasize this to the audience, think about this. They're different markets. Each of those different markets have different equipment. If you've got a broken ankle in one market, you may not want them to go to the urgent care because the x-ray machine isn't there. That level of permutation you're handling is phenomenal.
Yeah. Certainly there's a lot of commonality, right, with clinicians and the types of things that they see. However, to your point, we may have an urgent care that is a partner organization, right? It's not even something that we own in one particular market. We may not have urgent care at all in a different market. And so you're right. There is a kind of, not to oversimplify this, but kind of a decision tree matrix where what do we need them to do in that instance? And that's really where, we've been lucky to have clinicians that have bought in and understand the medium of chat and understand what this can do and help us to make sure that we're, appropriate in how that we're directing people. And, even if it's just simply sending them to information on the website somewhere, but ultimately to scheduling and things like that. So, yeah, absolutely.
And you've been on, dating back to your Texas Hospital Association days. You've led a lot of innovation projects across a lot of stakeholders. How did this innovation play inside of Ardent? What's the peer review looking like so far?
Yeah. That's a great question. I think this isn't much different than a lot of things that once somebody does it and there's pretty good feedback, then everybody else, either doesn't want to be left out or also wants to come in on it, right? Yeah. So I think the idea, and this is not uncommon in the hospital space or in healthcare on the provider side especially, but is the idea of beta or piloting programs and things like that. And so, for us, it's finding that clinical leader in this case that understands the value and says, you know what, I think there's a use case here. I'd love to be the guinea pig, right? And so you build that relationship with that clinician in this case, or those leaders within the organization, to kind of build that out, and then communicate early and often, provide some feedback on how things are going. And then, we're lucky enough that we've got a great system and leaders where, as we share this information, then it becomes apparent of, okay, well, here's the logical next step. And so I think, for us, it's probably, how quickly can we get it rolled out versus, trying to convince people that it's a good idea to quote unquote do it in their market, right? So.
Yeah, you're and let's take a look at the data here. You've got some impressive results. The last 3 quarters. So your deployment began. You actually went live in let's see, it was May of 2021. So you're a little more than 3 quarters into it. So this data is the trailing 3 quarters ending March 31st. Am I saying that right?
That's right. And I think, I want to be real clear. In my mind, we're really just on the front end of this. Like, I don't know that we've really maximized a lot of even what the opportunity is. These are just great indicators of really where we can go, right? And what the consumer's expectation is. And so if you look at those chat sessions, how those kind of fall out, it's really interesting, right? And it's not probably that different than what you would assume. People coming to a regional or community-based, hospital website would want, which is to have some sort of action-based experience. So, appointments and scheduling. So it's really interesting to me that half the folks, or a little over half, are there to create some sort of entry point into the system. And you couple that even with the finding care category. It's just, people want to take action. And so we're giving them that ability and kind of that transaction. So, it's, again, I think with integrations with Epic and some different things like that we've got on the horizon, we've got some really cool opportunities ahead of us. You see the hours saved over there. Again, this is from a self-service standpoint. So it kind of equates to call centers or contact centers. From a self-service model, there is a manpower component to this that we're able to offset. And so again, we're just kind of scratching the surface, but it's really encouraging so far that, the vast majority of the people that are using the tool are using it, meaningfully.
Yeah, it's impressive work. The fact that you're at scale, so you've got an enormous amount of data here. You're seeing great adoption. There's 2 questions that came up from the audience that I want to address. The first question comes from Robert Hollenbach. And he's asking, he understands it interfaces with MyChart, but can it be used to interface with other EHRs? I think he's referring to NetChat and Triage Bot. The answer to that question is yes. Most major EHR platforms can be integrated. And then a second question, they're asking, what vendor is Ardent and Loveless using? I suspect they're either referring to your EHR or they're referring to MedChat. Do you want to talk a little bit about that for a moment?
Yeah, certainly. So, we're using, and I'm happy to give anybody kind of a rundown of our tech stack, MarTech stack or whatnot, but we are an Epic organization. We have one instance of Epic that stretches across the entire enterprise. And then from a chat deployment standpoint using NetChat. So, yeah.
And to that end, your first stage, your go live last May in 2 markets. Talk about that cycle time.
Yeah, absolutely. So this is probably a broader, even kind of thought process than MedChat, right? But choosing a vendor, choosing a solution, choosing some technology. it's only really helpful once you can then use it. And so, so as you're onboarding things, this is certainly something that needs to be a part of that conversation and a part of that process of, okay, practically once we sign on the dotted line, when does this, impact our experience that the consumer's having, right? And so, excited that certainly, quickly we're able to get this stood up. And then, we talk about self-service from a consumer standpoint, self-service even from our developers and internally on our standpoint of being able to build and deploy these types of things, I think is really important too. So it's not 100% we have to rely on NetChat to do every little thing for us, and so we're able to go in and make changes and edits quickly, which is maybe even more important than just the initial deployment. So it's we can iterate and change and do quickly. So yeah, super happy about that, and feel excited that we're just kind of on the front end of this. So excited to see kind of where it goes.
There's so much here, so many interesting threads going on. So first of all, folks in the audience, if we welcome questions, so put them into the chat out there. And let's see, I think we've got a hello from James Tuckalon from Liberia. So welcome, James. And then Don, you want to cover these questions that Donna and Deb are asking? Oh, I guess just Donna.
Yeah, I will. I'll do that. There's a couple that I think one for the group, and then I have one for Heather as well that came in, and then I'll go on to the a broader question as well. So, question came in: does or how does a physician review process impact the enterprise implementation process?
Okay, so the physician review process. So this is the how do you it's the long pole in the tent, right? It's the and Heather, go for it.
I mean, certainly we could have taken what was standard and done that, and it would have been quicker. But we really feel it's important that we have that physician buy-in. They have to have their input in how we're managing their patients. And it doesn't. We had many meetings with the 3 different specialties that we put up. And it probably was a good 3 to 5 months of finalizing that the scoring and recommendation sets and getting their input on our workflows, that nature. But the engagement that we've gotten out of that and having those champions help us promote the tool now that we've had the pilot, that's invaluable. You have to have that in order to be successful, I think.
Yeah, and I think you're just as you think about that journey, that 5-month journey, that was it was a really interesting cycle, right? Because we would tweak the Triage Bot. You would engage the providers both so they could see what the consumer was going to experience, and they could wrap their heads around kind of the gnarly, complicated nuances. And you had an incredibly decisive group, right? Does that sound right?
Right. And it's something that we have to consider as we add. I think that was the bigger lift. I think we're starting from a different point now as we engage with different specialties. We're looking at including cardiology now. And so, I think we've learned some things to help us narrow that time frame, but it will still take time to get that consensus and that buy-in for each specialty we add.
And Reed, this question is interesting in the context of Ardent, right? Because while it's a challenge, it's a different challenge that you have because you don't have, sort of this centralized function. The flip side is the reason for that is your markets are incredibly agile. And in your setting, I think your both markets took, we had it up on the screen earlier, both markets took less than 76 days. So that was different because each of those markets had a smaller decision-making group. And really there was one or two clinical leaders. Talk about that.
Yeah, that's right. I mean, I think certainly the first time is the longest one, right? And then you can kind of iterate after that, sometimes a little quicker. And so, it's easy for us to go, okay, well, here's the deployment in this market. And if we're doing that same basic deployment, we can replicate that across our other markets, obviously very quickly. But as we, again, we're lucky enough to have some physician leaders that, already kind of have, for lack of a better word, kind of that standing within the organization, right? So they're the ones we're going to go to get this feedback. Everybody's kind of already philosophically bought in that they're the ones to kind of lead these types of initiatives. So it did make it where, we could kind of shrink the input down to, just the people, a few people. So, yeah.
And there's a million really interesting threads to this part, but Don, other questions from the audience?
Yeah, so one's for the group as well. It's a great question since we've all been experiencing lots and lots of automation, especially the last 2 years. This came in from Donna Griffin. The question is, we experience patients complaining that they're tired of everything being automated or using technology. They want to speak to a live person. Have you, Heather and Reed, experienced that in your feedback or seen that in your feedback?
We have not, at least not meaningfully at this point. I'm sure we will, and there is a line there. So I'm not saying this is the only way to do things. This is not a either or. It's kind of an addition or a supplement in a lot of cases to some of our live agents, or where we don't have that ability at all. And so they may be calling in to like literally the PBX of the hospital or to a physician's office or something like that. So again, this is a supplement for us in trying to create a way that we know a lot of people are wanting to engage with us, but we have not had any overwhelming or any sort of pushback to this point. But it is important to meet everybody kind of where they are.
And the way we're using it is obviously it's agent facing for the chat bot, but we're looking at other use cases that would be self-serve. And really, we like to offer multiple channels for people to interact, and they can choose the channel that they prefer. But we haven't gotten feedback.
Don, we probably have time for one or two more questions.
Yeah, let's do this one. And I'd like to say to the audience, if we don't get to your question, we will certainly respond to it directly with you. But this is a great question. How is the system used for scheduling outpatient services, specific to imaging, diagnostic imaging, breast imaging, MRIs, et cetera?
Wow. So there's a lot to unpack in answering that question. We probably won't be successful in the 1 minute remaining to dive into that. But the short answer is we've done all those use cases. The long answer is it takes a little bit of work to set it up, but once it's going, it's pretty easy to manage and pretty easy to modify. But with that, we're wrapping up here. So I think we probably should hand it back to Kelly. Thank you, panelists, Heather, Reed, and Don for joining the conversation today. For those in the audience, the slides are available, and there's a full bio for each of the panelists available as a download, which you can access through the webinar portal. Kelly?
Thank you so much. And I also want to take time to thank Heather, Reed, Matthew, and Don for this excellent presentation today, and also Isabel Healthcare for sponsoring today's webinar. And also want to mention that to learn more about the content presented today, please feel free to check out the resources section on your webinar console and also fill out the post-webinar survey. And thank you, everyone, for joining us today, and we hope that everyone has a wonderful afternoon.
Take care now. Thanks, everybody.
Thanks. Bye.